So just a few, I'm going to pick kind of some of these top disorders and give you a little bit of an overview. And you're going to take a deep dive later in the actual day so that you can kind of understand what this looks like. But benign positional vertigo, or BPPV, you've probably heard before. It's been described as rocks in your head or crystals. And the long and short of it is that there's literally rocks in your head. We all have them. You want them. They're supposed to be there, but they're not supposed to move out of the position they're designed to live in. And so when they come out of the position they're supposed to be in, they cause a very, very intense but brief bout of vertigo. So it's like a true spinning sensation. It's lasting usually less than a minute. So usually it's going to be seconds up to a minute, and then the symptoms stop. And so literally the symptoms stop when that little calcium deposit or the rock or the actual crystal moves back to kind of a resting position. So I'm not going to get too into this, but you're going to get a whole talk on this today that's extremely interesting. This type of vertigo sort of is like a wave a magic wand and goes away kind of vertigo for most patients. So upwards of 85% of patients will get a treatment or two and move on with their lives. So it is a pretty simple treatment for a lot of patients. And same diagnostically, it's pretty easy to see in patients. The eyes move a really funny way, so you can see on the schematic. They don't just move side to side or up and down. If you're dealing with the back canal, so the bottom canal is called the posterior canal, the eyes torque. They kind of move in this really funny torsional fashion. So for us, what we're looking at is nystagmus. We're looking at eye movement. All of our testing is done under goggles. It's really important for our clinic and for a lot of clinics worldwide to use goggles because we can figure out which canal, right or left, up or down, or even the side canal involvement. And then it helps us with the treatment too. The fun fact that I wanted to put on here is that residual symptoms after BPPV can actually last for months. And so we're going to have a pretty interesting talk on this later. But it wouldn't be the spinning that's happening any longer for patients. It would be any imbalance, unsteadiness, disequilibrium that they still are having after the treatment of the spinning. So the other one that we're going to kind of touch on is going to be vestibular neuritis or labyrinthitis. So the main difference with this is really going to be, is the hearing affected or not? And so with this, a virus basically enters the system. And with labyrinthitis, you're going to have a change in hearing and a change in balance. And so having a comprehensive audiological eval or looking at the hearing is going to be important. Because sometimes patients are coming in and they say, it feels really full in my ear, or it feels like maybe the right ear hears differently than the other. Taking the guesswork out, is it fullness in the ear or is it change in hearing of the ear, is going to be really important. The treatment for this is really going to be medical management, and it's very important that the physician is involved with regard to medical management of the patient initially. In most patients, a couple of weeks, they move on with their lives and they're fine. Sometimes they will need medical intervention that's going to include vestibular rehabilitation therapy in addition to any type of steroid or antibiotic regimen that the physician is going to recommend. But for the most part, most patients will get it. It's pretty nasty for, a couple of days or a couple of weeks, and then, they're completely resolved. Little fun fact on here again is going to be cold and flu season is actually the busiest time of the year for labyrinthitis and then vestibular neuritis. So Meniere's disease is going to be another one that I just wanted to touch on. Again, you will get a talk, but some of the hallmarks of this I think are really important to understand, because there are so many patients that will say, well, I have vertigo. Okay, what does that mean? Or I have Meniere's disease. I was told I have Meniere's disease. And so when you go in and actually try to understand what that means, and we go through, okay, do you have pretty intense bouts or drop attacks of vertigo that are lasting for hours at a time? Do you have roaring tinnitus where your ears really just kind of sound like somebody turned on a fan, or it sounds like just a whole jet engine kind of turns on? Do you have fullness in your ear or ears where you feel like it's literally full of liquid or fluid, or you need to pop your ears? And do you have fluctuating hearing loss? Is your hearing coming and going? Is it getting worse over time? So those all need to come together. Being evaluated by a neuro-otologist, or even a physician in general, that's going to be able to just allow you to kind of say what your symptoms are and kind of go through the boxes. Is it the vertigo? Is it the tinnitus? Is it the fullness in the ear? And is it the actual fluctuations that are documented over time of hearing loss? If it's one or none of those, it's not Meniere's. And so that's why it's important, again, to get the diagnostic testing. The ECOG testing and the audiological testing are very important for this patient population. So another fun fact is going to be Vincent van Gogh actually suffered from Meniere's. So migraine-associated vertigo is going to be, this is such an interesting, very, very interesting etiology, and there's so much work going into this right now with regard to research and treatment and how these patients are managed. So migraine in general is one of the most debilitating chronic conditions in the United States, and that's pretty similar throughout the world. And so what I think is one of the most important things to really note is that 40% of patients with migraine will have a vestibular component affecting their balance or dizziness. So that's really important to understand, because a lot of times when you say migraine, sometimes patients will say, well, I don't have headaches. I don't have headaches. Understanding what migraine-associated vertigo is and what it's not is very important. And so again, you're going to get a very comprehensive talk on this, but this is a very exciting piece of the puzzle as far as research and treatment that's coming out, because patients are starting to really understand what this management looks like and what it looks like to be managed medically, from a medication standpoint, from a supplement standpoint, but also dietary, what it looks like to be managed, from a trigger identification, and working with dietitians that are able to really go through and really make sense of anti-inflammatory diets and what specifically the triggers are to that specific person, which is really important. So the diagnostic criteria for migraine patients is, going to be a family history. Most patients have motion intolerance, even in childhood. They're presenting with vestibular symptoms, and there's a whole kind of checklist or tick list that's followed, when you're in front of the right specialist who understands what migraine-associated vertigo is. And if they don't understand it, getting you to the right specialist that's able to really go through and manage that condition for you.